We'll go ahead and get started. So thank you, those who are in the auditorium and those of us connecting on Zoom. Very excited today to have Dr. Adesina come present to us. So she is a national, if not international, expert on bone disease and sickle cell. And so when we're sort of thinking through our symposiums in areas that we don't have local expertise on, we were excited that Dr. Adesina is willing to present to us at 6:30 this morning in California. A little bit about Dr. Adesina. So she graduated with her BS in chemistry with honors from UC Berkeley, then went on to UCSF for medical school, then got her MS in epidemiology and clinical research at Stanford. Since then, she has moved over to University of California, Davis. And since 2021, she's been an assistant professor, but hopefully an associate professor based on my outstanding letter of recommendation, but hopefully we'll see about that later. So she has received several awards throughout her academic career. So she's had several prestigious career development grants. At Stanford, she was a KL2 scholar. Then when she went to University of Washington, she was a K-12 scholar. She was part of the NHLBI Pride program and was a scholar for functional translational genomics of blood disorders. She received an R21 from the Eunice Kennedy Shriver NICHD grant. She got a prestigious Doris Duke Charitable Foundation Clinical Scientist Development Award, and currently for another about year and a half is going to be funded through an NHLBI K23 Mentored Career Development Award. Not only is she an outstanding scientist, but she's also an outstanding clinician. And we know this because she was awarded the Outstanding Clinician Award by the UC Davis Internal Medicine Department. She has 13 manuscripts for in preparation, 2 book chapters, multiple regional and national invited presentations. So with that, hopefully I've convinced you that Dr. Adesina is a fantastic investigator who will teach us a lot about bone disease and sickle cell. Thank you very much.
Thank you, Dr. Lippensberger. Thank you for that very kind introduction. Good morning, everyone. I hope you can hear me okay. I'm going to go ahead and get started. So today I will be talking about my favorite aspect of sickle cell disease. And I will blatantly say that I stole this title from a young adult novel that my son read a few years ago. So I will talk about sickle cell disease and its impact on the bone, the skeletal system. All right, so for today, we will briefly mention some of the skeletal complications of sickle cell disease that all of us in the audience are very well aware of. And then we'll talk about some bone disease, sickle cell bone disease studies that I've been engaged in, others have been engaged in, and then future directions. So for this audience, you're very well aware of the multiple complications of sickle cell disease. I didn't go into the pathophysiology of sickle cell disease because that's something that you're all intimately aware of. But for the purposes of this talk in the short time that we have today, I wanted to focus on skeletal complications, specifically osteonecrosis, or as it's more commonly known, avascular necrosis, and bone loss, which is not as well recognized or it doesn't immediately come to the fore of mind when you think about skeletal complications of sickle cell disease. But my research and others are showing that this can also be a significant complication that causes pain. And why do we worry about skeletal complications? I think we should go a little bit further back and look at the evolution of pain phenotype in sickle cell disease. Once again, as we're all well aware of, pain is the hallmark of sickle cell disease. And in childhood, pain can occur episodically. And then what we think is happening is that there's some, obviously the underlying vaso-occlusive pathophysiology of sickle cell disease and the inflammatory milieu of sickle cell disease. We think that there is enough tissue injury that's happening where once it crosses a certain threshold, it becomes perceived as pain. And in childhood, we know that these happen episodically. Over time, somewhere between late adolescence and young adulthood, we think that some people have enough recurrent VOEs that cause tissue injury and inflammation that then they develop some peripheral or central sensitization, where the threshold at which they sense pain get decreased. And so even if the frequency of the episodes and the intensity of the episodes are not changing per se, the threshold at which we feel the pain is lower for a whole host of reasons that we don't have enough time to go into today. But because I take care of adults, I see a lot of chronic pain. It's generalized, there's hyperalgesia, not necessarily controlled by opioids, in fact, paradoxically worsened by chronic opioids because of opioid-induced hyperalgesia and then allodynia, where you're feeling pain even if you don't have a painful stimulus. And one of the reasons why I study skeletal complications is in the diagnostic criteria for chronic sickle cell disease pain, as I highlighted here, which is defined as having pain for most of the days in a 6-month period and having at least one of these signs, vascular necrosis, bone infection, and then there are other complications, but these are known contributory complications. And so my research program really focuses on understanding the pathophysiology and the epidemiology, trying to understand the risk factors that could lead us to develop evidence-based and effective treatment strategies to reduce the morbidity that comes from these skeletal complications, and hopefully in the long run, reduce the burden of chronic sickle cell disease pain. I'm going to segue into these two complications. Once again, osteonecrosis or avascular necrosis is very well recognized as a complication that leads to chronic pain, but low bone mineral density, it's unclear if it causes or if it's a result of having chronic pain. I'm going to dial a lot way back to the corporate study of sickle cell disease, which for its time back in the early 80s, late 70s, early 80s, was the landmark study of the natural history of sickle cell disease. So even back then, when people were not using hydroxyurea or disease-modifying therapies, it was well recognized that avascular necrosis or AVN was a significant problem. In the incorporated study of sickle cell disease, they followed about 3,000 patients over a period of about 3 or 4 years. And then of those, 2,600 of them were screened for AVN in the hips at study entry, and about 10% of those had hip AVN. And then they were followed for a period of about 3 years to understand the incidence of avascular necrosis of the hip in this patient population, and it was roughly about 9%. And what came out of that study that helped us understand one of the significant risk factors for AVN is that the incident rate per 100 person years was significantly higher in those with SS genotype with coincident alpha thalassemia trait. And then it was the lowest in those with ETC genotype. Fast forward to 2017, when I was writing my master's thesis, I wanted to better understand in the present time, and well, in a more contemporaneous time, this was, 8 years ago now, but I wanted to understand what the burden of hip AVN was using this database that we have here at UC Davis. At the time I was at Stanford, so I used to go from Palo Alto to Sacramento once a month in order to be part of this research program. But it was a really wonderful time in my life because it really honed in me this passion that has, sustained me all these years for understanding skeletal morbidity in this patient population. So as part of my master's thesis, I wanted to understand the true clinical burden of hip AVN in a large population database. So we didn't, have access to, we didn't have a longitudinal prospective study at that time, but I'll get into that a little bit later as well. So in this more recent time period, we use the iterative process that our group and others have published on extensively of identifying sickle cell patients in a very large administrative database. And administrative databases are not necessarily designed for research purposes. They're more for tracking and billing and that kind of thing. But if you're able to come up with an algorithm of identifying patients and identifying complications in these patients, you can actually answer a lot of real world observational data. So we looked at, we used an algorithm to define HIP-AVN, and then we looked to see what the potential associations or risk factors could be. So we stratified we had a little over 6,200 patients, roughly around 6,200 patients with sickle cell disease followed in the state of California between 1991 and 2013. And so we could follow these patients longitudinally because they had a record linkage number that would uniquely identify each patient. When we stratified our very, very large data set into those with a more severe phenotype, which we defined by frequency of admissions for management of pain, versus those with a less severe phenotype who had less frequent admissions or none at all. Well, they would have to have had admissions to be included in this data set, so they had fewer admissions than those with more severe phenotype. We could see that when we looked at the cumulative incidence of HIP-AVN, it separates out distinctly into those with more severe phenotype, having a much higher, threefold higher cumulative incidence of HIP-AVN versus those with the less severe phenotype. To give you an example, by around age 30, in those with a more severe phenotype, the cumulative incidence of HIP-AVN was about 24% compared to only 8% in those with less severe phenotype. Similarly, we looked at prior history of acute chest syndrome because other investigators had demonstrated that sickle cell disease does seem to fall into, as this audience is probably very well aware of, does seem to fall into two distinct, not necessarily non-overlapping, but two distinct subphenotypes. The viscosity vaso-occlusive subphenotype, of which AVN is part of, and then the hemolysis endothelial dysfunction phenotype, of which nephropathy and other things like stroke and priapism are part of. So we wanted to test this out in the real world with this large data set. So we did show that there is an association with more frequent vaso-occlusive episodes, or in our case, admission for vaso-occlusive episodes. And then there does also seem to be an association with having a prior history of acute chest syndrome. So all in all, our data was just showing that AVN is a significant morbidity in sickle cell disease, and it does seem to track with more severe disease and with other severe complications like acute chest syndrome. I was really curious, once again, because I was studying more on skeletal complications, and I was seeing and taking care of adults with significant skeletal morbidity. And so I was very curious about low bone mineral density, which others also had published extensively was highly prevalent in sickle cell disease. I was curious to see because I wanted to understand whether or not low bone density tracked with AVN. And so we just queried our data set at that time. So we just queried our data set, which I wanted to look at the prevalence using ICD-9-10 codes, the prevalence of low bone mineral density equivalents like osteopenia and osteoporosis in the general sickle cell disease population, and then compare that to the prevalence in those who we had identified as having HIP-AVN. And as you can see here, it's more than a twofold increase. So in the general sickle cell disease population, looking at all comers, we found about an 11% prevalence, so not an incident rate, but prevalence rate of low bone density, or in this case, osteopenia, osteoporosis. But when we dial down into those, the smaller subset of those with hip avascular necrosis, the prevalence was about 24%. Once again, this is just looking at the population that we had here in California. And why would that be? There are several factors that can contribute to development of low bone density in people with sickle cell disease and other chronic illnesses. And so I just wanted to just highlight for the audience the development, our skeletal development does start in early childhood. And males have, because of hormonal factors and other things, males do have a slightly higher or significantly higher, actually, bone density than females, and that separates out in adolescence. And so we are all, we were all accruing bone in childhood. And then around adolescence, you can see a significant separation as males do put on more bone density more so than females. but we all are seeing our peak bone mass in our 20s. In our mid-20s, thereabouts, is when we are seeing our peak bone mass. And then it does start to decline from then on. So we're not accruing more bone in our, past our 20s, but we do tend to start seeing a decline. And then that is accelerated in menopause for women or for females. And so there is a faster decline in bone loss after menopause, as you're well aware. However, in sickle cell disease and other chronic childhood diseases, the accrual of bone is significantly impaired by the underlying chronic illness, such that by the time people with sickle cell disease and other chronic illnesses reach their 20s, there's a significant difference of peak bone mass. And so, our patients are already at a significant disadvantage because they're not even anywhere close to their, in this case, genetic potential, because people of African ancestry also have significantly higher bone density than those of non-African ancestry. And as for our patients who are of African ancestry, they're not anywhere close to their genetic potential. And then as more complications of sickle cell disease progress with age, there are more insults, more things that are driving bone loss in our patients. So significant inflammation, hemolysis, other downstream effects of sickling drive bone loss. And so they don't have a long way to go at all. They're not at their peak. Their peak is much lower than people without sickle cell disease, and then they don't have very far to go before they get into their osteoporotic range. But what's interesting in sickle cell disease compared to something else like thalassemia is that our patients don't necessarily fracture, and we're not really truly sure why, but they don't necessarily fracture like those with thalassemia, but they do have significant chronic pain, which I think is inextricably linked to low bone density. There are multiple factors, in addition to suboptimal peak bone mass, that also impact bone strength. So decreased physical activity, puberty, delayed puberty, reduced muscle mass, and obviously the inflammatory mood of sickle cell disease. So in 2019, or actually a little bit earlier than that, in 2017, I started co-leading or co-chairing the bone working group of the Sickle Cell Clinical Research and Intervention Program, which is a longitudinal study of sickle cell disease that is maintained, that was started and initiated by my mentor, Jane Hampkins at St. Jude. And so Dr. Liebenberger and I are co-investigators on this longitudinal study. So I wanted to look at the impact of low bone density, or the burden of low bone density, in a more contemporary longitudinal cohort like SCRIP. And so our paper was published in 2019. We wanted to look at in children with sickle cell disease, children and adolescents. We roughly had about 300 children and adolescents enrolled in SCRIP at that time. We wanted to look at the burden of bone density, or low bone density or low bone mass in this population. And so just for the audience, really quickly, this is stuff that I'm steeped in, but I just want to roughly just explain what we do when we're doing bone density in children, or in adults for that matter. So a bone density scanner, or DEXA scanner, or dual X-ray axial-geometry scanner, or DEXA scanner, is what we use. It's simply an X-ray, but what we're doing is that we're looking at the volume of bone, obviously, which is a three-dimensional surface, but we're projecting it onto a DEXA scanner, which measures it like an X-ray. So it really is an X-ray, and it's converting the volumetric or density or volume of bone into a two-dimensional thing that would look like an X-ray. So a two-dimensional projection of a three-dimensional measurement, if that makes sense. So what we do specifically for children is we do the whole body. We also do the lumbar spine. In adults, we measure typically the left hip. If the left hip is compromised by avascular necrosis, then we do the contralateral hip. And then if both have hip ADN, which is highly, it often bilateral, then we can measure the forearm and then the lumbar spine as well. We can also do the lumbar spine in the sort of lateral view in order to look at compression fractures. And so for children, when we're measuring the bone density, we do subtract the head, which takes up a whole, it takes up a significant portion of their bone density. But what we measure is their total body minus the head. In script, when we look at these 300 plus children and adolescents, we did find that there was these are just bone density. They're just bone density, not converted to Z-scores or anything. But when we measure their raw bone density, we did find that roughly, and then we separated out by males and females because as I explained before, males and females attain peak bone mass at a very different rate. And so we found roughly about 44% of the females in this cohort had bone density measurements in around the fifth percentile, so significantly lower than a healthy population of African American children without sickle cell disease that we use as our comparison. It's really important to match not just for age and sex, but also for race if possible, because there are different genetic predispositions to bone accrual that don't necessarily follow race, but we find that if you if you try to adjust for race, which is a social construct, it may also account for those genetic predispositions. And so in males in this population, it was closer to 50%, so roughly about 47% of them had their bone density in the fifth percentile or less compared to healthy African American children. But our population there was quite a lot of short stature in our population as well. Roughly about 10% of both males and females had their height was also less than the fifth percentile for the healthy controls, and roughly about 60% of them had height in less than 50th percentile. So it's critical because you are when you're calculating bone density, you must adjust for height in children because once again, it's sort of a volume. It's a volume that you're measuring, but you're projecting as a surface area. So you have to adjust for height because obviously taller children will have more volume or more bone density, but you must adjust for that. That's not really captured when you do the calculation into a surface area. So you must adjust for their height. And so I'll walk you through this. This was the sort of home point of this project or this paper. The adolescents are represented by the open circle, and the school-age children, defined as ages 6 to 12, are represented by the open red triangles. We define bone density as being low when your bone density score, your Z-score, is less than -2, which means that it's 2 standard deviations below the mean. So when you look at the vertical axis, this is the unadjusted aerial bone mineral density for age for our population. So anybody that was under this sort of these two lower quadrants met criteria for having low bone density because their Z-scores was less than -2. In the open circles of the adolescents, it was roughly 35% of the population. And in the open red triangles of the school-age children, it was roughly 25%. However, when you look at the horizontal axis, which is height-adjusted bone mineral density Z-scores, now we're looking at the left quadrant for those who meet criteria for low bone density. Once again, those with a bone density Z-score less than -2. When you look at these two quadrants here on the left side, you can see that you barely see any red triangle. So when you adjust for height, that significantly attenuates or significantly it significantly changes the actual measurement of bone density. We still have 25% of the adolescents, so the open black circles, 25% of them still met criteria for very low bone mass or low bone density, even after adjusting for height. But in children, it was only 4%. So oftentimes when in the literature up until that point, when we had seen bone density reported for children with sickle cell disease, it was these astronomical numbers, but it was because we were not fully adjusting for height in these patients. And so it really does help a multidisciplinary approach. This project involved myself, obviously, from hematology, but we had a lot of bone physiologists, radiologists, and then biostatisticians, obviously, involved in the project. And that's why I think we're able to demonstrate this for the first time in our patient population. And then another novel finding from the paper was we wanted to, like I said, one of my interests was obviously understanding chronic pain in this patient population and how that ties in with bone density. So when we looked at a multivariable linear regression model and put hip osteonecrosis into that model, in addition to chronic pain, which we define as having pain enough to be prescribed oral opioids for 6 months or greater, we found that there was a strong odds ratio, a high increased odds ratio for having low bone density if you have hip osteonecrosis, and there was also an association with chronic pain. So, increased odds of having chronic pain if you have low bone density, which had not been reported before. So that's one research question that's answered leads to 10 more that are unanswered. So I really wanted to understand the burden of low bone density and pain and the association between the way that I reframed it was we know that AVN significantly contributed to chronic pain, but I wanted to understand how low bone density, whether or not there was some sort of association between low bone density and whether it was driving part of association that we knew. So I wanted to understand the relationship between bone density and pain in adults and between bone density and osteonecrosis in adults as well. For my K23 and my Doris Duke, the first aim was studying a cohort of adults with sickle cell disease followed here at UC Davis. We had wanted to enroll 50 adults. We ended up enrolling 53. And we obtained their bone density scans and their lumbar spine, their hip, their forearm. And then we also scanned their whole body, not because we wanted bone density of the whole body. That's not how it's measured in adults. But we wanted to obtain their fat and lean muscle mass as part of our analysis. And then we also, in the same scanner, we could have the patient lay on their side and get their thoracolumbar lateral x-ray, basically, to look at compression fractures. And then we had each patient complete a patient-reported outcome measure, the ASME pain measure, pain impact score, actually. And we wanted to correlate that with their bone densities and their bone density Z-scores and their vertebral fracture analysis. This is a modified table 1 from our paper that's currently under review. And so just to highlight for the audience the baseline characteristics for our patients, we had 53 patients overall. So, a small study, but roughly about 70% of them had S beta 0, and we had one patient with SD. Roughly half of them were prescribed hydroxyurea. 45% of them had chronic pain, were on chronic opioids for pain management. 42 had osteonecrosis, and we found a prevalence of 43% of low bone density in this patient population. Some of the factors associated with low bone density was most prevalent in the lumbar spine. But some of the factors that were associated was lower hemoglobin, higher indirect bilirubin, higher white count, and concomitant use of crizanlizumab. So that kind of we weren't appropriately powered to look at inflammation per se, but it does seem that hemolysis, so lower hemoglobin, higher indirect bilirubin, and an elevated white count, or a more sort of severe phenotype of sickle cell disease requiring the use of crizanlizumab, in addition to hydroxyurea, did seem to track with our patients with low lumbar spine bone density scores. And then, like I said, we also measured pain impact in these patients. Obviously, chronic opioid therapy associates with pain, positively associates with pain. We also used EGFR, which I shouldn't have used. I know Dr. Liebensberger is on the call, but this is what we had to measure for these patients here in this study. But it did seem like reduced EGFR was associated with more pain or more self-report of pain impact, and then higher phosphorus and ALT. But what was interesting was particular interest to me was looking at the association between lumbar spine bone density scores. That also seemed it did have a positive association with pain, although it did not meet statistical significance, presumably because of our small sample size. When we stratified our patients' pain scores by their bone density, so I'll walk you through this. In the red signifies those patients in our study who also had concomitant osteonecrosis, and the blue are those who don't have osteonecrosis. And then the black circles, the filled circles, are those on chronic opioids, and the open circles are those not on chronic opioids. When you look at the normal bone density group, there really was no difference in the pain scores in those with and without osteoporosis. There was a difference in the amount of those taking opioids, right? With about 35% of the patients with AVN who had normal bone density taking chronic opioids, and only about 15% of those without AVN who also had normal bone density taking opioids. Interestingly, when we look at the low bone density subcategory, there was a significant difference in the pain scores in those with AVN and low bone density compared to those with low bone density without AVN. So obviously AVN is a big driving factor for pain, but low bone density in and of itself also seems to be a driving factor. The pain scores were significantly different, and the opioid utilization was significantly different. And the sample size was small. All 5 patients, or 100% of them, who were on who had low bone density and AVN were on chronic opioids, and roughly about 60% of patients who had low bone density without AVN were on chronic opioids. So what this highlights is, once again, we didn't, because of the small sample size, we couldn't really obviously determine causality. We could only determine associations, but we are not sure if low bone density is a precursor. So is it like a sort of a canary in the coal mine? Is it a precursor of those who then have pain complications or chronic pain down the line? Or is it a bystander, or is it a consequence of having pain? So as you can imagine, if patients have chronic pain, they're not very physically active. They do have a decreased muscle mass, which without the appropriate muscle mass, you can't accrue enough bone. So we don't really know. We're not really just like a chicken and egg situation, but there does seem to be an association that does seem to be a signal, which I'm hoping to study in a larger epidemiologic study again, looking at some of these outcomes. I'm going to segue now. We have some other studies that stemmed out of the K23. So I got internal funding from our radiology department to look at patients with sickle cell disease. UC Davis is one of 2 institutions in the country at this time when this grant was awarded. Only one of 2 institutions in the country with the ability to do a total body PET CT. A total body PET CT gives us the advantage of getting images faster, scanning the patient's entire body at a very low dose of radiation. Also, you can use bone-specific radio tracers that go to areas of increased bone turnover. What we use at UC Davis is the 18 fluoride sodium fluoride radio tracer. It hones the area of significant bone turnover. And also when you inject the radio tracer, my radiology or nuclear medicine colleagues have a way of doing these extensive mathematical equations to understand how bone blood flows in and out of the bone using this specific radio tracer. So we enrolled roughly 20. We enrolled 24 patients and eventually scanned 22 of the patients in our total body PET CT. 22 patients with sickle cell disease. So I just wanted to show you some of the images from just one particular patient, once again, just for time's sake. And so to walk you through it, it's kind of thinking about when you're looking at a PET scan for malignancy. So this, once again, it's not FDG, it's not glucose. This is sodium fluoride, which hones to the bone. And so in the orange, things in the sort of orange, red, whitish area are sodium fluoride avid, which indicates areas of significant bone turnover. And then in the darker colors, like the green and sort of the darker green, these are areas where there's no bone turnover. It's not sodium fluoride avid. This is a lateral image or a sagittal view of the whole spine of one of the patients enrolled in the study, a 33-year-old female with hemoglobin S beta plus. And she, let's see, has significant complications, even though she's more, and we think of S beta plus as a more or less severe phenotype of sickle cell or genotype of sickle cell disease. This particular patient has significant complications from her underlying sickle cell disease. And so just to look at the sagittal view of the lateral spine, you can see the classic things that we see on x-rays, but highlighted significantly in this patient. So looking at, these are SUV images. So on the left is just the CT, on the right is just the PET, and then in the middle is the fused CT. The right is just the PET images, the left is the CT, and on the middle are the fused images of the PET CT with us being able to look at areas of radiotracer avidity. And so in this particular patient, on the sagittal view, you can see that each vertebrae would just represent significant wedge compression fractures in the anterior portion of their lumbar spine or their thoracolumbar spine. And then you can see the classic fish mouth, which also indicate compression or crush fractures in the middle portion of the vertebrae. These are things that are reported. You see it all the time in our patients when they undergo x-rays or CT scans. You can see it clearly here on the fused images. And another one that I wanted to show you was looking at the coronal view of this patient's femoral shafts and the top images, and then looking at sort of an expanded or magnified view of the distal right femur at the bottom view. What you can see in here, it's not very, it might not be very clear, but what we can see in this, in the top view in the area is significant bone turnover or avidity for sodium fluoride in the pelvic region for this patient, which tracks to what we think of. There's a lot of bone marrow in that area and a lot of bone marrow turnover in that area, and then decreased avidity or decreased uptake of the radiotracer in the femoral head. This patient had early stage AVN. What's really interesting when we look at the lateral view is you can see this. There's a terminology that radiologists call bone in bone. So you can see areas of sort of bone formation. As adults, we shouldn't be forming any more bone in the shafts of our, like we're done, right? We're done accruing bone. So we shouldn't be forming any more new bone in the shafts of our long bones. But you can see in this patient, probably areas of bone infarction and her body attempting to heal itself or heal those infarctions. We see that phenomena of bone within bone, which is not seen at all or not expected at all in adults, but it's something that we are seeing for the first time in patients with sickle cell disease in this small study. And then lastly, I wanted to look at a more magnified view of the left femoral head and the right femoral head in this patient. Once again, on the left side, these are all CT images, and then on the right side are PET images, and the middle are fused. And when we look at this particular patient, there's reduced uptake, as you can see in the sort of fused images. There's reduced uptake in the subchondral region of the femoral head and the trochanter. It correlates probably with she has AVN. And then there's a slight sclerotic region in the top right part of her right femur that also seems to track with decreased uptake of the sodium fluoride tracer in this particular patient. So this study, we're still analyzing the data. We completed the study just this past February, and so it's taking, this is sort of new territory for me to look at all these images and try to piece together a clinical story. But what we're starting to see is there's significant, as we all know, significant skeletal morbidity in this patient population, and that does seem to track with areas of prior bone infarct and areas of avascular necrosis and other areas of that we were not expecting. We were not expecting to see that bone within bone in the shaft. And so we're still going through all the images, looking at all the SUV or the uptake of the sodium fluoride tracer in these areas and trying to piece together regional abnormalities in this patient population and put that into a clinical picture. I'm going to segue into the very last part, and so I'll make sure I leave enough time for questions, looking at the role of bisphosphonates in this patient population and biomarkers of bone turnover and pain in this patient population. So others have looked at bisphosphonates in pediatric patients with sickle cell disease. This is a paper, it's now about 3 years old now, published from colleagues in Canada, looking at skeletal outcomes. So their images are very similar to our images, minus the PET portion of it, obviously, but looking at CT scans, X-rays, MRIs of their patients. This is a much younger cohort than what we studied. I think the mean age was about 11 years old, but they found significant morbidity in children as young as significant skeletal morbidity in children as young as 2 in their patient population. And what was really interesting is that for some of the patients in the study, I think overall they presented data on 46 patients. About 23 or half of them were received intravenous bisphosphonates as part of managing their skeletal morbidity. The lead author on this paper is an endocrinologist, actually. It's been really, really fun getting to talk to her about our shared interest in sickle cell bone disease. But they treated some of their, about 23 patients with intractable bone pain, so not responsive to opioids, not responsive to NSAIDs, and other pain treatment modalities. They treated them with zoledronic acid or Zometa, and a few of them with pamidronate, and demonstrated significant reduction in pain in this young cohort with sickle cell disease. In one of the patients, an adolescent male, they actually went a step further and obtained a transiliac bone biopsy to look at the extent of bone turnover in this young patient, this young man, who had received Zometa for a period of about 2 years. Pre-Zometa, you can see there's a significant thinning of his cortex. It's only about 46% of the expected width, and there's also significant trabecular degradation with significant bone turnover, about 3x of what you would expect in a 16-year-old male. He received Zometa for a period for 6 months or so, in 6-month intervals for a period of about 2 years, and then they repeated the transiliac bone biopsy and demonstrated as about a 20% improvement in his, actually a 35% improvement in his cortex over time, and decrease in the bone turnover or trabecular degradation in this patient after he received Zometa. So a significant and remarkable difference in this patient. They have since gone on to treat others, including some of our patients actually, or in the way that I would describe that is that we, in close communication with them, have actually guided the treatment of 2 teenage boys at not at UC Davis, but at other affiliates or with other colleagues using their same approach with significant improvement in the pain of these patients who previously had intractable pain, even though they were receiving very high doses of opioids and NSAIDs. And so we published a case report and a brief review of some of the potential for bisphosphonates in this patient population. What we think might be going on and why bisphosphonates might be helpful is that there are many, many factors that lead to bone degradation, not just necrosis, but to potentially fractures and obviously bone density issues. You can have iron overload, physical inactivity from frequent pain. There's the highly inflammatory milieu of sickle cell disease. we also have a high prevalence of low vitamin D and possibly like low lean muscle mass in these patients, and obviously the endocrinopathy oftentimes tied in with iron overload in our patient population. So all these factors can contribute to bone degradation. And treating these patients, a select patients with bisphosphonates might actually improve some of these skeletal outcomes. So we have here at UC Davis, this is a cartoon of the second portion of my K23, where we are enrolling about 25 patients, or about 30 patients with AVN in their hips and their shoulders, treating them with alendronate, which is an oral bisphosphonate that's given once a week, measuring our feasibility markers or feasibility endpoints of retention and recruitment, measuring bone biomarkers, inflammatory biomarkers, adhesion biomarkers in these patients, and also obtaining a PET-CT pre and post treatment with alendronate to see if we won't see any changes in a 6-month clinical study on the bone density. It takes quite a while for you to see accrue or improvement in bone density, but we do think the PET-CT is sensitive enough to be able to pick up differences in bone blood flow in patients, regional bone blood flow in these patients with alendronate treatment or other bisphosphonate treatments. And this has been shown in other patient populations with arthritides where they've been treated with bisphosphonates and seen differences within a 6 to 12-month period on PET-CT. In summary, I will end this by saying that skeletal morbidity is highly prevalent in our patient population. It does increase with age and disease severity, and it does associate with significant chronic pain in our patient population. We do strongly believe that optimizing bone health, bone density in our patients in childhood may over time lead to less decreased prevalence of chronic pain in our patient population when they get to adulthood. And then there is a role for bisphosphonates in this patient population, but this still needs to be carefully studied to make sure that we're doing this safely. And so with that, I want to thank you all for your attention and acknowledge all my funding sources and my colleagues and mentors here at UC Davis and beyond, obviously, for being significant contributors and making a significant impact in my research career and helping me do this study and this research that I love in these patients. So thank you for your attention. I'm happy to take questions. Oh, I realized that I apologize. I realized that the stark sunshine here is blocking my view, so I'm just going to lower my face 1 second.
Fantastic job. Open up to questions, and I'll go ahead and start. So, and I have a few, so I'll just give you one at a time. In terms of pediatrics, the things we could do both from a screening and for, especially with physical activity sort of comments in terms of how we talk to our children. So what would you think would be the best screening, at what time, and then how can we try to improve at least the non-sickle cell related bone mineral density issues, particularly with physical activity?
Yeah, that's a great question. So right now there aren't any guidelines of when to screen people with sickle cell disease. Actually, I'll take that back. The International Society of Clinical Densitometry, so those who oversee bone density measures in patients, do recommend screening children and adolescents with chronic health conditions that can impact the bone, of which sickle cell disease obviously is one of those. They don't recommend a specific age, but they do. They don't recommend specific age for people with chronic illnesses, but in the general population, they do recommend screening from the guidelines for when you can diagnose bone loss starts from age 10. So they have a definition of when you would say, a child has low bone density. The way that they actually describe it is if a child has bone mineral density Z-scores, either in the total body or in the lumbar spine, that is -2 or worse around age 10, they are considered as having low bone density for their age. But that's not enough to say that they have low bone density. They also have to have had two fractures, at least two fractures in their long bones, and which is highly prevalent because children move around all the time. And so that's the recommendation from the ISCD for children. In adolescents, you've had to have had at least 3 fractures in the long bones, in addition to bone density being less than negative, bone density Z-scores being less than -2. And so we can extrapolate that from the general population into the sickle cell population. So in SCRIP, which is that longitudinal study from St. Jude, they screen children at least once between the ages of 6 to 12, at least once again as adolescents, so between 12 to 18. And then there's a growing population of young adults in that as the children in SCRIP get older. There's a growing population of young adults that we're also screening with DEXA scans. So in answer to your question, it would probably be the sort of the most holistic or big picture way would be to get a DEXA scan in these patients around age 10, and then again, probably in adolescence. And that way you can have a way to longitudinally see if they're losing bone or not accruing bone properly as they're getting older. I hope that answered your question. And and then with the question of physical activity, any amount of physical activity is great. I know it's not necessarily, when I take care of adults, and so oftentimes they're not really engaged in physical activity, but I do encourage, moderate physical activity. As if patients are dealing with pain, that might be a bit of a challenge to do, but walking, um, uh, things that you do have to sort of bear weight, actually. So I'm not sure if swimming would be one of it, but walking is excellent actually for helping you with lean muscle mass development, and also weight bearing, because you do have to have mechanical forces on the bone in order for it to develop properly. And so the lean muscle mass does pull on the bone, which is helpful, but you also have to have some sort of weight bearing activity on the bone as well in order for it to accrue properly. So I that's kind of extrapolating from the general population, but that's what I think would be beneficial for our patient population as well.
Okay, thank you. Other
You're welcome.
questions?
There was a question in the chat. Let's see. What do you do with those patients with SCD who have osteopenia? So that's a really great question. So patients with low bone density. So once again, this is something that I see a lot in adults with sickle cell disease. I don't necessarily recommend bisphosphonates as the first line of treatment in these patients. What I do try to do is make sure that they are replete in vitamin D. So low vitamin D is also highly prevalent. Although in our study, we didn't see a strong association between vitamin D levels and bone density. And I do recommend at least having the building blocks. As the way that I would think about it is you need to have it. You need to have adequate amount of vitamin D and calcium and phosphorus for that matter in order to be able to. These are like the building blocks of hydroxyapatite, which is the main protein in bone. So you need to have those. So vitamin D is what I recommend. I also recommend, that they eat a calcium-rich diet. But a lot of patients, where we can get the most amount of calcium is in milk and yogurt and other dairy products. And a lot of patients aren't necessarily are lactose intolerant, and so are not necessarily taking or eating a calcium-rich diet. So you can also think about supplementing calcium. Oftentimes calcium is it's a calcium vitamin D co-supplement. I also recommend like I said, I also recommend a moderate physical activity, even in the adults, even if they have chronic pain. I do recommend, if you can, if not obviously when you're not having an acute crisis, but even if you have lived with daily chronic pain, some amount of moderate physical activity can also help with some of that, with some of the pain if the patient can tolerate it. Let's see. Question.
Yeah, Torin had a question.
Yes, let's see. It says, thank you so much for the commendation. It say, I have quick questions. It's a high prevalence of AVN in the shoulder and hip in patients with C disease. Have you noticed this as well? Yes. We did stratify our study and look at other studies as well. There does seem to be a higher, not statistically significant, but probably clinically significant proportion of patients with SC disease. In my study, roughly 25% of the patients had SC, and there did seem to be a higher prevalence of osteonecrosis in the SC group compared to the SS beta 0. What I think is going on is these patients have a higher baseline hemoglobin because of their underlying genotype. And so we know that AVN does seem to track with that viscosity, vaso-occlusion subphenotype of sickle cell disease, which does tie in with having a higher baseline hemoglobin. For patients with SS disease, those are patients who also have coincident alpha thalassemia. So what I think is going on is those with SS, and even in that image that I showed you, that person had S beta plus, but has a high baseline hemoglobin of about 10 or so. And so I do think that that might be contributing to the development of AVN because they might have not necessarily hyperviscosity, but they might have sort of more. I'm not really sure, to be honest, why AVN would be more prevalent in those with a higher baseline hemoglobin, even if they're non-SS. But we do see that. We do see that, and others have reported that as well. And then the second question from Haroon was, in regard to the use of bisphosphonates, is there a preference on the type? So no, there isn't a preference. In the study from Canada, they used Zometa, zoledronic acid, more so than pamidronate. I think for ease of administration and the fact that you know that you're giving the patient Zometa. In my study, because Zometa is expensive, I'm using alendronate, which can be given once a week, and it's very, very cheap. So there isn't necessarily a preference, but others have published more on Zometa in this patient population, in our patient population than in the general population. So hope that answers that question as well.
And then can I ask another question real quick? Again, obviously getting DEXA from an insurance standpoint all the time is an issue, but any correlation with the vertebral changes we see in sickle cell between that and bone mineral density? Because we see that all the time when we get chest x-rays, they'll comment on the collapse of the vertebral issues that we see. But have you looked at that correlation as a potentially cheap marker for, do we need to go on to get a DEXA in this patient?
Excellent question. So yes, in our study, we did look at the thoracolumbar spine. We used a DEXA scan, but we could have used an X-ray as well. So we did measure. We're still analyzing it actually to see in the individual thoracal. So it's supposed to be T10 to T12 and L1 to L5. So looking at each individual vertebrae and trying to associate that with their overall bone density. Well, the overall bone density is just that of the lumbar spine, so L1 to L4, but there will be a correlation. We're still studying that and analyzing that. We had a lot of technical difficulties because of the imaging quality of the DEXA scan / X-ray. So a lot of the patients who had participated in my bone density study, about half of them were in the Total Body Explorer study. So the Explorer images are much clearer, much more. We can pick out the vertebrae compression in the PET-CT better than we could in the DEXA scan. So we're still trying to overlay or correlate those two and then look at its association with bone density. But you bring up a really good point. DEXAs aren't very expensive, but right now they aren't in the guidelines for measuring. And so you could get pushback, obviously, from insurance because of that. But we get X-rays all the time. We get CT scans. Well, in adults, we get CT scans all the time. But so yes, you do bring up an excellent point. We can probably potentially extract information from the spine to give you an estimate of what the patient's bone density is. In our study and in others, we did show that bone density in the spine, it does seem that low bone density is more prevalent in the spine, and we think that's because the spine has more trabecular bone, more so than the hip and the forearm, which has more cortical bone. But anyway, I hope that answered your question, Jeff.
Yeah, and then Dr. I will have the last and final question about correlation between MRI spine and DEXA?
Let's see. MRI, yes. So MRI is excellent, obviously, for looking at AVM. We don't usually use MRI to assess bone density in patients. It's better for soft tissue. It's also better for subtle sclerotic changes in the sort of femoral head and the humeral head that you can't pick up on X-ray. But a CT scan does seem to be a little bit more correlated with a DEXA scan more so than an MRI. The MRI is excellent, though, for early stage AVN because you can pick up those tiny sclerotic changes or subtle sclerotic changes. But it is much better for soft tissue than it is for bone. The DEXA or a CT scan is better.
All right, fantastic job. Definitely answered a lot of my questions when it came to, hey, we need some additional training on how to handle bone disease and sickle cell. So thank you very much.
Thank you for having me.
Greatly appreciate, again, you joining us at 6:30 a.m. Out in sunny California.
Thank you. Thank you all so much for having me. Thank you. Bye. Have a great day. Bye.